This is Brian Wormers recording a lecture for postoperative nursing for the medical surgical nursing class. Here are learning objectives. And so postoperative period, this is as soon as they come out of the operating room and becomes into the PACU ambulatory care unit or ICU, in which we're recovering the patient. So within this, we're often looking at different projects for patient status improvement. So you can see here the SCIPs or the different core measures that we're looking at. But really at this time, we're really worried about things such as pneumonia, shock, cardiac arrest, respiratory arrest, DVTs, GI bleeding, and wound infection. Postoperatively, the respiratory system is crucial. We want to make sure that airway is clean, that they've got adequate gas exchange. If they've got an airway in place, whether that's an ET tube, a trach, an LMA, LPA, or an NPA, that is patent and it's working. We want to make sure that they've got good rate respirations, depth of breathing, pattern of breathing. You want to take a listen, make sure that they've got bowel sound or breath sounds bilaterally. We want to look and make sure that they're not using major accessory muscles because they'll get tired out with that one. We want to assess for any snoring or stridor, which could be indicative of upper airway swelling. And then, of course, if they've got respiratory depression and not breathing well, that's an issue. Cardiovascular wise, we're looking at heart sounds, blood pressure, heart rate, all those fun things. Looking for pulses, looking for capillary refill time, all those different tools that you guys have to look at cardiac monitoring. We also want to monitor for VTE, so venous thromboembolism. So looking for any calf pain, looking at any swelling of the pain, looking for any difficulties in breathing from a pulmonary embolism. All those things can happen after surgery and are too common. Neurological, we're looking for cerebral functioning. Are they returning back to their baseline? We can check that using AVPU or classical coma scales. We can also look at their motor function. Are they able to follow simple commands, move their extremities, and return to that baseline where they're at prior to surgery? We want to monitor their fluid, electrolyte, and acid-base balance by doing I's and O's, looking at their hydration status. Continue to run any IV fluids, looking for anything where they're losing fluids such as vomitus, urine, wound drainage, NG drainage. And then, of course, if they're losing some of that stuff, either through vomiting, diarrhea, NG, or wound, we have to monitor their acid-base balance very closely. We want to look for urinary retention to make sure that they can void prior to being discharged from the operating, or to make sure that they're getting enough urine output. Most adults should have greater than 30 mils per hour, and if it's less than that, it should be reported. So GI system, so vomiting is very common. Oftentimes we try and give things prior to surgery, such as Zofran, to reduce that, but it still can happen. Generally speaking, if they've had surgery and they've puked before, they're at a higher risk for it the next time. They may also have some peristalsis in their GI tract. This can be delayed up to 24 hours. We want to monitor for bowel sounds. Once those bowel sounds come back, then we can start increasing the diet. Prior to that, though, if we start feeding them and their GI tract is not ready yet, this is going to cause an obstruction. It's going to cause complications. So, other indicators for intestinal activity definitely is passage of gas or stool. And this is often your gold standard. Other things we want to do, as I mentioned before, is to reduce that nausea and vomiting, and this can be with the following meds. We do want to monitor NG tube drainings. We do have to make sure that this tube, if it was placed in surgery and they've had any GI surgery done, that it stays in place. We use that to decompress that stomach, promote some GI rest, try to prevent any ulcerations happening from the hydrochloric acid being static there. This can also provide enteral feedings, and we're really trying to decompress the stomach so we don't get bowel obstruction. So we should assess this. Your book says about every 8 hours or so. I really like to do it on an hourly basis and just monitor that drainage. If this happens to fall out, during a GI procedure, notify the surgeon right away. Do not try and put it back in because if they've had any surgery around that site, you run the risk of going through that surgical site. Skin assessment. So, we're all hoping for normal wound healing, um, and that can happen, about 14 days after surgery. It's a gradual process leading up to that. We can see some impaired wound healing. This is more common in patients that are obese, have diabetes mellitus, or we're on a lot of steroids. Complications, especially around the GI tract, we can talk about dehiscence, where it's breaking open, or we can talk about evisceration, when you get protrusion of the internal organs through that wound. If you see dehiscence or evisceration, you should take a gauze, soak it in some saline, and put it on there and have it up against there to provide some support, and then call the provider immediately. You might see some of these different drains. So things like a simple Penrose drain, a T drain, and here's one that's coming out of the body. You can see a JP drain, a hemovac, and here's a JP drain placed inside this person. After surgery, they are going to experience some discomfort. It's a normal finding, it's an expected finding. We probably cannot eliminate all of their post-surgical pain, but we really try to get them down to a level that's tolerable. Usually we try for 3 and under if we can. Kind of review some of those physical and emotional signs of pains. Are they being quiet? Is their heart rate up? Is their blood pressure up? Are they screaming? Are they crying? Are they just telling you that they're in pain? What are these things that you're noticing on your patient? With this, you might have to give medications. This can be either one-time doses. This can be oral if they're with it enough. This can be IV. This can be IM. This can be through different devices. So all this is going to vary depending on what kind of surgery they had done, what's the expected pain that they're supposed to be having, and how they tolerated meds in the past. So one of the last things I want you to be aware of is the 5 Ws. This after surgery, it is common for them to have some fever, but these are some of the reasons why. So within the first 24 hours, we usually chalk it up to the anesthetic drugs. After that, we're looking for things such as UTIs, we're looking for atelectasis or pneumonia, DVTs, surgical wound infections, or maybe the antibiotics that they're on afterwards. So this concludes this video presentation. If you have any questions, please talk to your instructor.